And I'm very excited to welcome Jennifer Ford and Patricia MacTaggart for our very first presentation for BTOES Healthcare. So I'll do a brief introduction for Jennifer and Patricia. Hello, Jennifer. Jennifer has been working within the healthcare industry for almost 20 years and is the Director of the Quality Management and Value Division within the Veterans Health Administration, VHA, which focuses on the effectiveness and value of all VHA major investments and interventions. These investments require strategic direction and evidence-based assessment in order to maximize the intended value of the healthcare outcomes. Mrs. Ford specializes in high reliability organizations, healthcare access, care within the community, knowledge management, and health IT programs and products, to include the electronics health record. She also has been a professor for over 6 years and teaches at George Washington University. And then we have Patricia MacTaggart with us. In addition to being a Master's of Health Administration, Master's of Health Information Administration, and Master's of Public Health teacher, instructor, and program director at George Washington University, Ms. MacTaggart currently has an appointment as a program manager at the Veterans Health Administration. An executive public service for over 40 years, Ms. MacTaggart has led national efforts in the areas of data, quality, service delivery, and information management. It's a real honor to have both of you with us, and we're very much excited about watching your presentation today.
Thank you, Jose. And welcome, world. It's exciting to be here, and I'm very pleased to be able to have the opportunity to speak with you over the next 40 minutes or so about VHA scheduling system, which we call the Pathway to Access High Reliability Realization. But first, before we get into that, I'd like to talk to you about how we transformed our own organization to really be able to answer the question, how do you know? With all the billions of dollars we spend on healthcare within the VA, the real question is, how do we know our transformations are effective and valuable to everyone, our veteran patients, our providers, our administration in general? So a little history. So back in 2007, I was directly asked to create an organization that would help us understand, how do we know our health IT systems are yielding the benefits and the value that they were intended? We had about $350 million a year worth of enhancements and over $500 million a year worth of maintenance that we had on our EHR system. So our roots were really in health IT. By 2010, interestingly enough, the VA went through 16 major transformation portfolios, in which 2 of them were directly related to healthcare. One of those portfolios, healthcare efficiency, was one of our major transformations to, get us more towards higher efficiencies and effectiveness and value. So even though our roots were in health IT, the Principal Deputy Undersecretary for Health had this vision that we really needed to focus on the business side of healthcare as well, and asked me if our processes and proven methodologies would work on other type of investments and interventions, such as revenue cycle management, our beneficiary travel systems, our operational excellence, and so on and so forth. So I said, I don't see any reason why our proven methodologies couldn't work on all portfolios within the VA that include all people, processes, business drivers, and technology. So over the next few years, as the transformations were occurring, we were able to apply our methodologies and really gave that insight into how do you know your business transformations are happening effectively and of value. So that kind of is what leads me to my next slide and talking about access. So just a little bit of background here. What was the need for transformation and access? Some of you may have heard back in 2014, the VA had major challenges with access, which reached congressional levels. We really had a whistleblower at one of our sites that said that we had excessive timeliness issues to access for our veterans, which were directly causing patient safety and quality issues. So it was really the first demonstration. The international, or the Institute of Medicine had determined that access is a first entree into patient safety and quality, but really didn't have a lot of the evidence behind that as much as in 2014, VA really demonstrated that access was the pathway to patient safety and quality, and some of our challenges demonstrated that. So what were our findings on what was the problem? Well, the first problem was we didn't really have an access definition. There were so many relationships when it came to access, we really didn't define all of those relationships. We also saw that access was the first step to determining patient care. It was the absolute first touch point, and that our scheduling system was the foundational piece to that. The other interesting thing is our delivery system. When you look at our delivery system, we have a closed system. We have a finite budget. We don't have an arm, an extension of funding that helps us with surges. Many of you may not know that we are the largest integrated healthcare network in the country. We have 172 hospitals and over 1,000 community-based outpatient clinics. We have 9 million plus veteran patients that are enrolled and eligible to use our system, and about 5 to 6 million at any one time uniquely in multiples are accessing our system with multiple appointments. What we did find is that also our access is very complex. You don't necessarily have under one roof every single specialty when it comes to outpatient consultation, outpatient surgery, and inpatient surgery and inpatient units. We have all of that under one roof on 172 hospitals across the entire United States, whether it's rural, suburban, or city settings. The other interesting fact of our system is our population. Our population is one of the sickest populations in the country. Most of our veterans are elderly and have several comorbidities that are very complex in terms of the care plan of our patient. And then we also ensure that we have the care for all those comorbidities integrated so that our patient is getting true patient-centered care. So at the end of the day, what does this mean? It means that really when you look at the definition of access and you assess what access really means, it's one specialty at one facility at one point of time. And so what that means is that a facility could have, 50 specialties that 48 of them may be, operating just fine, and 2 might be a problem. Whether you may not have the space or you may not have the number of providers needed. But unfortunately for us, because we have a big public lens on us and congressional oversight, those 2 specialties will hit the papers, and we will get recognized as having some issues with access. Now, I'm not saying that we shouldn't have those 2 specialties, operating excellently for access either, but the problem is that it's a lot and it's very complex. So our healthcare delivery system, from a timeliness perspective, is very hard to track and understand the data. But before I even move on, I also want to talk about a personal situation that I experienced directly. So this is also in the private sector. So I was very sick, and I couldn't. It was a sickness that was kind of covert. Had some blood work done. My primary care doctor recognized that I needed to see a specialist, recommended me to a specialist that he knew very well, faxed my paperwork, my blood work over, and I tried to get an appointment, and I called every minute of the day, and the scheduler just kept telling me, no, we don't have any appointments. You're going to have to wait a week. So every day I was going downhill, and at the end of the day, I did end up in the emergency room. Unfortunately, that was an unnecessary visit, and once I did, I mean, it's necessary because I was going downhill, but if the provider saw me sooner, that was going to be an unnecessary visit. I did get stabilized, and I finally went to my doctor, only to find out that when I asked about my paperwork that was faxed over, the scheduler literally went over to the fax machine and was sitting there. So obviously over a week, my paperwork was sitting on the fax machine. Finally got into the doctor's office, and he looked at my condition, not only my blood work, but how I looked. And his first words were, "Why didn't you see me sooner?" After that situation, plus the VA situation, I did have a passion to help transform this area of healthcare, which was the gateway, into safety, patient safety, quality, and value of care. And at the end of the day, what we realized is the first step, the very first foundational piece, was starting with the scheduling system. All right, so let's talk about our scheduling system for a second. Now, you have to understand that VA was the first organization to really put out an integrated electronic health record that had all the EHR modules necessary to function as a healthcare organization. Our scheduling system was part of that EHR, and it's over 40 years old. Now, our scheduling system that is still in effect right now is antiquated. It actually has a blue screen, roll and scroll. We have put a GUI, graphical user interface, on top of that as of to date, but it still has very limited workflow in it, and very limited business rules to take you through the veteran-patient pathway through access. It's a clinic-based system, which means that every single resource in the organization, whether it be a provider, meaning a doctor or a nurse, a machine, a cardiology machine or an MRI machine, any type of equipment needs an appointment grid. And then what makes it really difficult is the scheduler has to match up. If the provider needs the other resource, the scheduler has to match up the provider with the resource at the same time so that they're both available to the patient at the same time. So our system was in dire need of an overhaul. So you might say, well, geez, why did it take you this long to figure that out? We figured it out a while ago, and we've had many significant attempts to overhaul our system, but there was a couple of issues. Number one, for those of you who know legacy systems over 40 years, much of the code is gone. There's a lot of intricacy that is embedded that is hard to uncover. You can't lose patient data, lose patient information. So it's very hard to overhaul a system like that, especially when it's integrated so deeply like ours. The other issue is that the COTS products of the past, the commercial off-the-shelf products, didn't have all the functionality that the VA needed or the capabilities that were any better than what we had in our system. So unfortunately, the maturity in the industry took a while to just not even catch up to us, but surpass us enough to where we were able to take advantage of that new capability and technology. So there was a maturity in the system. So what we decided to do was acquire a commercial off-the-shelf system, and we called the project MASS, M-A-S-S, Medical Appointment Scheduling System. And if this was to be successful as an overhaul of our scheduling system, it would have been the first in our history to overhaul a legacy system with a COTS product. So as we were acquiring our new system, we were really getting to work. What we did was we needed a baseline. How did our system operate today, and what was good about it? Let's make sure we capture that. And what did we really, really need to change? What kind of capability did we need in order to make it way better than what it was today, besides the obvious of the roll and scroll and the GUI on top of that? So what we did was we did a deep dive into a subset of specialties that were very critical. And what we did was we did a causational analysis of that, meaning when we did a deep dive, every time we found a pain point, every time we found a point of failure, and every time we found a best practice, we were not only documenting that into a very concrete benefits realization framework, but we were also feeding the acquisition team to say what was needed in our new system in order for it to be highly successful. So therefore, our benefits realization framework ended up with over 300 measures and metrics that really look to transform the areas of access, such as demand, supply, practice management. In other words, how we function as an organization. What are our business drivers and our policies? Our space and equipment, because we have limited space in our facilities, so we would have to acquire more space if we acquired more doctors, as an example. And of course, our budget was a big factor into our analysis. And what that yielded was measures and metrics that fell under each of those 5 major benefits, such as satisfaction, utilization, timeliness to care, those types of things. And my colleague, Patricia MacTaggart, will talk to you about those results a little bit later in the presentation. So what we did was we then collected data from the benefits realization framework with all of those 300 metrics that were both quantitative and qualitative, and arrived at our baseline. And this was the also demonstrated the value, or basically the business case, of why our system needed to be overhauled. And essentially the business case was really the big need for change. All right, next slide, please. Oh, sorry about that. I think I just talked about most of this. One more slide, please. So here's what the big ta-da was. Here's the big aha moment. What it really boiled down to when we did the baseline was one major issue, is that our VISTA scheduling system did not answer, how do we know? How do we know we are achieving access to care? How do we know we're doing it in a timely manner and in an effective and valuable manner? The VISTA system, with all of its functions, really boiled down to one thing. It was like a basic calculator. So as our schedulers were scheduling for very complex scheduling events, such as, if you had diabetes and you needed to be able to, you had to go to your endocrinologist and you had to go to your podiatrist and ophthalmologist and make sure all of those appointments were scheduled and in the order that they needed to be in. None of that workflow, none of that business rule was in the VISTA system. So what was happening is our schedulers were doing all of that business intelligence, what we call outside of the system. So we had no idea where the patient was in their care plan. We had no idea except for when the scheduler recorded it. So just like a calculator, if you were to say 2 + 3 = 5, the input of 2 and the input of 3, we don't know how you arrived at those numbers. We just know that 2 + 3 = 5. Same type of thing with VISTA scheduling. There was much more complexity to it, obviously, but if it really had to boil down to it, there was no transparency in the system at all. MAS, on the other hand, provided all of that functionality that we acquired. It demonstrated those many-to-many relationships. It took us through the workflow. It was able to guide us through those business drivers and business rules. And we were really able to pull all of the resources together so our schedulers would not have to check every single resource to schedule a one-time scheduling event. All of it was pulled together from a resource management perspective. And so what it really did is it not only provided us the capabilities that we needed, but the transparency that we so desperately were yearning for, as well as the decision-making capabilities, so that we could ensure that our access was, up to par, being managed at the right time, at the right place, in the right modality. So now I have the privilege of turning over to my colleague, Patricia MacTaggart, and she's going to actually go through many of the results that we had that you're probably eager to hear about. Patricia?
Good morning, afternoon, evening, depending where you're at. Unless you can validate the impact of the improvement, the benefit realization of the human, financial, and time investment is always in question. The reasons the VA made the operational changes in the scheduling system are threefold, and they are the same reasons you would consider a change. The first is to meet clinical and operational strategic goals. And for the VA, that's improving veteran access to services and enhancing the veteran's experience and engagement. Since scheduling is the first step to access, and access the pathway to quality and patient safety, one of the significant direct impacts of the VA scheduling system redesign effort was the improvement to access. The scheduling system enhancement processes included technology that was innovative and improved veteran access. VA added MyChart, which is the patient-facing online portal that allows veterans to create, modify, and cancel a direct scheduling appointment, reducing the burden on schedulers and allowing veterans to select the appointment day and time that works best for them, potentially reducing no-show rates. Some of the documented value impacts of the changes include that veterans are canceling their primary care appointments prior to the appointment, allowing the medical facility to rebook the appointment, making providers more productive and avoiding wasted space and human resources. The number of consults that were open greater than 30 days decreased, providing better connectivity, continuity of care, and less wait time to see the specialist. And most importantly, the number of completed appointments increased, validating that veterans were able to get the services they needed at the time they needed it for the best clinical outcomes. The second reason any of us would undergo a change would to make the technology, processes, and people more efficient, so clinical and your operational staff can be more productive and able to serve more patients. For VA scheduling, this was accomplished through decreasing manual, paper-driven processes and enhancing the usability of the technology. As a result of resource-based workflow and process efficiencies, it now takes less time to schedule or cancel an appointment, and the timing of recall reminders has improved. Consult completions were improved through the use of an automated scheduler work queue that allows the scheduler in real time to know what consults and return to clinic orders have been acted on and which ones need action. Previously, schedulers used paper lists to track throughout the day. Now there's less potential for missed opportunities, schedulers are more productive, and the appointment wait times for veterans has gone down. One of the biggest impacts of the new system is that schedulers can schedule both personnel and non-personnel resources, such as space and equipment, which the previous system would not do. For example, a cardiologist may have multiple clinics, pulmonary, stress, pacemaker, EKG, arrhythmia, on any given day. In the previous scheduling system, each provider would have one schedule per clinic and would need to print out in the morning each individual clinical schedule, track it in paper, compile the paper copies for each clinic schedule, and then manage his or her day based on the schedule that existed at the time of the printing, which again was at the start of the day. With the new system, the same cardiologist has one schedule with the resources needed for the appointments attached for one consolidated and electronic provider schedule. Not only does that make it easier for the provider to identify where he or she needs to be, it allows the providers to accommodate changes in veteran demand. Mass also automated many manual processes, reducing potential points of failure in the scheduling process. Another example of a positive impact of decreased manual processes was the reduction for some community caseworkers of their overtime by 62%. Not only does that create staff satisfaction, but administrative costs are reduced. In addition, we have all seen how healthcare needs have become more complex and multifaceted, resulting in patients needing recurring appointments and interconnected appointments such as lab and x-ray before a specialty appointment for diagnosis. The new system is able to make these appointments more easily and without errors, reducing unnecessary variation and waste. Think about the value to your organization. If you could reduce the time it takes to schedule or cancel an appointment by up to 3 minutes per appointment. Like VA, your appointment staff would have more time to communicate with your patients. Think about the value to your organization if you could increase same-day appointments across high-priority specialties such as oncology or cardiology or physical therapy, and decrease the average wait time for mental health, an issue that is being addressed by both public and private healthcare deliveries. This would be real business value, and it is a real business value for VA. Improved access, improved clinical care, and improved provider and patient satisfaction. The third reason for systemic operational change is to provide real-time data and analytics and real information to your administrative operational staff and your clinical staff so they can gain a better understanding of supply, demand, and their needs. Mass provided VA medical facilities transparency as well as evidence-based, real-time, actionable information to decision makers about productivity, quality of care, and the fiscal impact of their scheduling system transformation, which allowed them to optimize resource utilization and enhance their decision making. The results have validated the business value to date. So what is the impact of future access high reliability realization? Jennifer.
Oh, thank you. That was great, Patricia. So where did we take this? So we took our rigorous analysis. We had a incredibly complex 300 measure benefits realization framework. We measured our baseline. We took the same framework and applied it to mass. And you just heard the results that Patricia explained from the comparison of the before and after. And we had this huge success. We had the first time ever ability to change out a Vista system with a COTS product, and again, with huge success. So where did we take this? So we presented our findings to the Undersecretary of Health, which actually created a monumental immediate decision to then replace all scheduling systems in the VA well ahead of, and if you haven't heard, VA is replacing its entire EHR with a COTS product, an $18 billion venture over 10 years. And instead of waiting for every facility to adopt the new EHR, the decision that we helped to create was to immediately change out the scheduling system first ahead of the EHR implementation, because it was that critical to patient safety and quality of care to do so, as we just demonstrated. This decision was a multi-billion-dollar decision on top of the $18 billion decision already to replace our EHR, making it one of the largest business transformations in healthcare history to date. Congress took our findings and adopted them, overwhelmingly approved the ability for us to finance the new vision and direction to change out our scheduling system first. And we were basically on our way to higher reliability to access through our scheduling system. We are proud of our proven methodologies of how to optimize these systems and continuously improve our processes, becoming a major learning organization, not just within the VA, but also in the healthcare industry in general. We are proud to be able to present this to such a platform of leaders that are looking for this type of, how do you know your business transformation is successful, that it's yielding the expected benefits, that I really was able to optimize and claim success for the types of investments and interventions we are making on a daily basis. I really thank you for taking the time to be with us this morning, and I'm excited to hear any questions that you may have for us today. Thank you.
Jennifer, terrific presentation. Jennifer and Patricia, thank you so much. We have had a number of questions come up, and I'm going to relay those to you. So thank you again for a terrific presentation. First of all, one of the first questions that has emerged in the commentary as well has to do with the scale of what you're doing here. I think it's hard for people to understand, especially those who are outside of the United States, kind of the order of magnitude scale of what you have. So you talk about, I think, $18 billion implementation or something like that. And then tell us a little bit just about the scope of this thing. I mean, order of magnitude, an estimate, how many people are affected here who participate in the scheduling system? You talk about 12 different areas of practice in multiple sites. Just give us kind of an order of magnitude scope of what this looks like.
Again, let's start high and drill down. We're the largest integrated healthcare system in the country and probably rivals in the world. We have 170, so if we have 50 states plus Puerto Rico, well, we have 172 hospitals, just the hospital facilities across the nation, which touch on city settings, suburban settings, and rural settings. Just because our veterans are in rural settings, we have to service them anywhere, which makes us very unique because we can, again, we're not a profit center. We don't need to look at a profit and loss statement to understand how our reach has to affect all of our population. So that's kind of number one. So then we have tentacles that branch off of those facilities, and each facility has at least probably 10 community-based outreach clinics. So those clinics have usually primary care, behavioral health, and then several specialties depending on, again, the population needs of that population location and catchment area. Now, within what also is very unique, within each facility, most of our facilities are of the highest complexity, what we call 1A, B, and C, which means it entails every single specialty with the exception of a few specialties that are very specialized at maybe certain universities, like certain kind of, brain surgeries and whatnot may entail. But having that kind of reach across the United States, that many facilities, that many people, hundreds of thousands of appointments across the enterprise per minute, it becomes an enormous, turning the Titanic when you're saying, well, why don't you just replace the scheduling system? It is a monumentous, not only tasker, but the decision to do something like that is so highly disruptive and transformational that you really have to have your evidence-based information really, tight so that when you make that decision, you can look Congress in the face and say, this is why we made it, and this is the progress, and this is how we know.
And I think to add to that, one of the risks that we find in large transformations is that people try to roll things up and do it at a very high level. And as what Jennifer said earlier, this is specialty by specialty, drilling down, because how you do care for oncology and the resources involved in that are very different than what you're going to do for cardiology or physical therapy. So the numbers may roll up and you may not be able to identify that point of failure that is impacting your business processes and the clinical care you're providing your provider. So it's even more complex because you need to drill down and then bring it back up.
Right.
Fascinating the scope of this transformation. And if you gotta eat an elephant, you gotta eat one bite at a time. And we look at this elephant, and I'm curious about even how do you even create your core team? What does that look like in terms of your core team? How many people are participating? in the very beginning on that core team? What does that look like?
So I have a core team of specialists that help with the measurement of this transformation. The transformations themselves take, many core teams to actually implement. We actually don't do the implementation. We tag along with the implementation to provide the how do you know? How do you know, this step was successful, and we build it. We don't just come in at the end. As I mentioned in the presentation, we make sure that we were feeding the acquisition team what was necessary so that when they finally acquired the system, they knew the pitfalls they needed to solve. So, it is a very core team of specialists that we also acquire other resources to come in and out depending on the flavor of the day. Like I mentioned, we do this across the board. You introduced with high reliability, access, community care, and so many other types of healthcare delivery in general. This was just an example with scheduling, one example of hundreds of assessments, thousands of assessments, tens of thousands of knowledge artifacts that we have in this how do you know you transformed effectively.
And I think one of the things is the skill sets. Jennifer's put together teams of people who have technology expertise. We have people who have business processes expertise. We have measurement expertise. No one person has all the expertise, but it's putting the team together. And the approach is very much utilizing and observing the activities of the people doing it. We go out to the facilities and do on-site observations. We look at their data. We scrutinize the data and the data definitions to make sure that we're comparing apples to apples. We have technology folks that go through the foundational and functional system processes, and then we go and look at the workflow and what they actually do and how they actually do it. That's where you find the potential opportunities for improvement.
Every time we found opportunities, they would turn into a measurement in that overall framework.
Very good. Just one more question kind of on setting the stage that has emerged. It has to do with just a rough timeline of, because this is such a large, complex transformation. When did it start? I mean, how it progressed over the months and years, and then where you at in that process? Is it completely done? And what does that look like from a timeline perspective?
Right. If you see me looking down, I'm looking at Jose, so I'm not looking away. I'm looking at you talking. Well, like I mentioned, we've tried to transform scheduling for many, many years, and like I said, there was many difficulties with it. But back in 2014, I'm sure many of you can go Google VA 2014 scheduling or access issues. It comes right up, and it's no secret that we were in desperate need of transformation. So how do you even take on this this kind of enormity? It does take time. You have to have I think that the proven methodology that we have and the approach that we take is very effective, very efficient, because what we do is, like Patricia said, we go into every facility. At first, we were going to look at every single specialty and found that was just going to be way too daunting. So we did get a representative 12 specialty sample that were very complex, that had many of the comorbidities that our veterans had, and we did a very rigorous 12 site process to make sure that we didn't uncover any significant nuances from site to site to site, and if we did, we documented it. So we felt that we had a very good enough sampling, and that took probably a year to do all of that, because it is a lot of analysis. And one of the issues that we have as organizations is we have data, but we don't have a lot of business intelligence with that data. So that business intelligence, what we found, had to be done manually, and that was very daunting over time. So like Patricia said, we didn't have definitions. We were rolling up specialty care, and we were, when you rolled it up, we were meeting our specialty care tenfold, but then when you unraveled it, it was because maybe, optometry was seeing their patients 100%, but others were seeing their patients at a 50% interval, and that was just not acceptable. So when you really unravel this, the baseline took really a good year, which also, like I said, allowed us to feed the acquisition team and acquire, certain acquisitions take time, and then there was probably an 8 to 9 month rollout, implementation rollout of the system. Once, and actually it was only within 2 weeks of the end date from when the end date was identified from the start, which was pretty miraculous. It was about an 8 to 9 month rollout. Once the rollout happened, you cannot measure right away. You have to wait because there's kinks, it has to normalize, there's going to be people that don't understand, need to be retrained, whatnot. But our leadership needed answers right away. I mean, this was being watched every minute of the day. So we did do a very quick 4 month initial measurement and compared it back to Vista scheduling. And there were some very significant business transformation qualitative information that really did provide the evidence to move forward with the system. But just to make sure, we did one more partial measurement at the 7 month mark to make sure that we were not only confirming those initial measurements, but we're also gaining some of the more strategic benefits like to access and whatnot. So it is a process, and you do have to stay patient, although some of our leaders aren't very patient, but we were trying to give them the best information. But what we didn't want to do is we did not want to compromise the quality of our assessment with a quicker, maybe not so analyzed measure. So we were, ensuring that what the information we gave them was real.
And to follow up on that, Jennifer, that very last stage of implementation, thereabouts, what year did that take place, roughly?
It was 2018.
2018. So you're looking for, 2014 to 2018, which is an incredible transformation at this magnitude and that time frame, and it does take time for something of this magnitude to take hold. It's really fascinating. Well, I want to go to very specific questions here. I think we have enough questions to talk all day long, so I'm going to do the best here to summarize some of these questions. And again, for those of you who submitted questions or are unable to get the answers, you can contact us. You can go on LinkedIn under the posting that we have for this and post some of your questions there, and I'll certainly pass them on to Jennifer and Patricia. But this comes from William Fuller, and William asks, first of all, everybody's saying great presentation. Thank you, very real about and very well done, the transformation itself and the way you present it. The question from William is, did the VHA use static process maps, simulations, what if scenarios, or a combination of tools in this transformation? And was integration done in-house or by external suppliers?
So the integration was done by the COTS, the commercial off-the-shelf external suppliers. The people who provided the software did do the integration, so they were one team. We did not have an outside consulting team do the implementation, so they were one team. So that actually, I think, was a benefit. To the other question is, yes, we did create scenarios. What we called them was veteran pathways. We created 8 very complex representative scenarios that we actually on site traveled through the process as if we were the veteran, literally going from clinic to clinic to make sure that our information was transferring at the time through the clinic, and that what was expected to be there in terms of information was there. So we did do a lot of those process maps and what we called the veteran pathways.
Very good. I have the next question here from Cameron Jahan Shahi. Good to see you, Cameron. Cameron has been a presenter in our conferences, certainly a member of our audience who's very engaged in our presentations. He says, great presentation, Patricia and Jennifer. I am curious, did you also work on reducing last-minute cancellations by patients? And if so, can you elaborate on that? And then he has a follow-up on what kind of training and change management was required to ensure that this new scheduling system sticks?
Yes, two very complex and excellent questions. It's the question on everybody's mind. Well, let me answer the second one just because that one's the freshest in my mind right now. But from a training and change management perspective, the COTS product provider did provide the training of the system. And then we did have super champions at the site to be able to understand what the new business processes were, the new business drivers, to be able to do it on-site, train the trainer on a constant basis. And that was a critical change for success. Now, one of the major issues, though, is that, again, this is why you have to look at it specialty by specialty. Certain specialties said, this is great. I didn't know I had this capability, and they were extremely innovative in their new processes. Other specialties kind of just force-fitted their old process into the new process and didn't really take advantage of the new technology. And that's part of the transformation, and that's part of this measurement. We measure that to know who's kind of the leader, the innovative leader, and who are the ones that might need some help in adopting the new technology. So we are in that, again, just like any change, that's a process. That's going to be a 2 to 3 year process change over and over again until all specialties are kind of up on the same floor in the elevator and taking advantage of those capabilities. I'm sorry, Jose, what was the first question, part of that question again?
No, you did a very good job in addressing that, and we're running against time here, so I'll ask for just the first portion of that question, if you can address that quickly. Had to do with if you got into last-minute cancellations by patients, if that's an issue that you had to deal with or maybe attacked as part of this.
So one of our issues is we don't charge a no-show fee. There's no incentive to, for our veterans, if they don't show up, they don't, there's no penalty. So that is a really big issue for us. However, the new system, the old system could do some of this tracking and tracing. The problem with it, though, is that, again, it was all manual business intelligence. You had to really take months to dive into the data. The new system, however, that was one of the requirements, and it actually had AI tools to be able to track that so that we might find that information out ahead of time and be able to really, take those open slots and fill them quicker before it's too late and the time slot had passed. Because if you look at the VA, we're a closed system, we're basically firm fixed price. Even if you average $175 an hour for each, or a slot that it goes unused, when you have, at one point in 2017, it was 9.2 million no-shows. Just do the math, and you're in the billions at this point in time. So that was a very big business driver for us to make this change so that we could get that capability to determine those last-minute slots not going filled, or looking at kind of those offenders and being prepared for that, and understanding who we can put in those slots ahead of time.
I also think one nuance to go to the person who asked the question specifically, we got down to the nuances of things like texting. There is a benefit of texting a reminder. There is a real benefit of having the veteran or the patient commit to whether they're going to come, or rescheduling ahead of time so you can rebook the schedule. It's that level of detail that allows you to know what works and what doesn't work. And that was a very specific example that relates to dealing with no-shows.
Jennifer and Patricia, thank you so much. This is a wonderful presentation, wonderful work, and your presentation reflects the great work and leadership that you have had on this incredible project. Many people thankful for the work that you do for our veterans and society, and really creating an important positive change in our world. So thank you. Probably a lot more questions that we could ask, and that we'll follow those up on LinkedIn, and we'll get those to you as well, as many as possible. Thank you so much for sharing your journey with us today.
I appreciate it. Thank you, everyone.
Ladies and gentlemen, that was just a flavor of for the day. What an incredible multi-billion-dollar transformation in engaging hundreds of thousands, if not millions, of patients in the United States, and probably in locations outside the United States as well. We didn't even get into that component. Terrific. And at the top of the hour, we're going to be closing this segment now. And at the top of the hour, we're going to follow that up with two incredible thought leaders on healthcare as well. We're going to welcome Dr. William Maples and Jennifer Krippner. Dr. William Maples is the President and Chief Executive Officer of the Institute for Healthcare Excellence. And Jennifer Krippner is the Chief Experience Officer for the Institute of Healthcare Excellence. And they're going to talk about creating a culture to promote individual and team thriving, resiliency, and peak performance. So we're gonna again hear directly from industry experts and on how to successfully transform our organizations, our healthcare organizations. So look forward to see you back at the top of the hour. We'll take a quick break now, and I'll close the session, and I'll see you back soon. Thank you.